Mar. Charmin here. So excited to be here and to discuss some medicine with my good friend, um, the one and only Dr. Penner. We actually thought, hey, yeah, Jack, you want to say hi?
Sure. Good morning. Good morning. Good afternoon. Good evening. Hello, everyone. Thanks for joining us today. It's a good Wednesday. A cozy group this morning, but I'm excited. I'm excited for this case today.
Me too, because you know what? Drum rolls, the one and only Yusuf is presenting a case. Hey, do you want to say hi?
Hi everyone, so excited for the case today.
We are very excited as well. We can get started. If you all don't mind sharing the whiteboard. Awesome. The mic is yours.
So this is the case of a 69-year-old male who was transferred from another hospital for dyspnea and a new oxygen requirement. The patient has a history of CKD, hypertension, coronary artery disease, diabetes, and AFib. You got it, Marino. Was initially admitted for necrotizing fasciitis to the ortho and spine hospital, underwent debridement. However, the course was complicated by MSSA bacteremia. And over the last 24 hours, developed this new oxygen requirement, was initially on 2 liters of oxygen nasal cannula and is now on 10 liters. I'm going to pause right there and then I can give you more information afterwards.
All right. This is a super rich start. So I mean, I guess just to sort of summarize the problem space that it sounds like we're in, we have shortness of breath, hypoxemia on a background of a recent severe illness, right? Neck fash is by no means a benign skin and soft tissue infection, as well as a recent history of Staph aureus bacteremia. And so if we just look at the primary problem that we're going to focus on here, which is to say shortness of breath and hypoxemia, what I'm actually doing cognitively is I'm sort of actually crossing out the shortness of breath and just focusing on the hypoxemia. And that's because if we look at those two problems together, anything that is causing hypoxemia is likely going to be the primary driver of this patient's shortness of breath. And I find that there's maybe a bit more of a targeted approach that we can take in analyzing the hypoxemia in this context than just the shortness of breath alone, right? If we look at those two Venn diagrams, there is a huge overlap between them. There are some things that cause shortness of breath that don't cause hypoxemia. For example, anemia and acidosis. So those are going to fall out of our schema. And then when we look at the hypoxemia here, right, we can just focus primarily on saying, okay, well, what are the things that could drive hypoxemia? And honestly, there are so many ways to think about hypoxemia. What my brain is doing in this moment is sort of focusing on an anatomical approach and say, okay, there can be alveolar problems that cause hypoxemia. There can be airway problems that cause hypoxemia. There can be interstitial problems that cause hypoxemia, and there can be vascular problems that cause hypoxemia. And if we were to take those 4 things, again, the alveoli, the airway, the interstitium, and the vessels, and say which of those seem most probable here, what I'm focusing on primarily is the alveoli and the vessels. And the vessels, we could think about things possibly like a pulmonary embolism, right? This is somebody who has a recent surgery, so is in the post-operative state after debridement, which we know carries an increased risk for VTE. We also have these episodes of MSSA bacteremia, and certainly Staph aureus bacteremia can lead to the development of pulmonary emboli, particularly if somebody develops endocarditis, right-sided endocarditis in the setting of that Staph aureus bacteremia. So that's one vascular cause that we can think of here. Another vascular cause that would be atypical to drive pulmonary or to drive hypoxemia like this, but certainly belongs on our list to hold in the background would be something like acute pulmonary hypertension or acute on chronic pulmonary hypertension. That could be in the setting, again, of some sort of pulmonary vascular process like a PE. Moving into the alveolar causes, right? Certainly infections can do it, right? Pneumonia as an alveolar filling process that causes pulmonary that causes hypoxemia, and then heart failure. And we can certainly potentially draw a straight line between MSSA bacteremia and heart failure, with the moderating element being endocarditis. And so I think that helps me think about sort of what's the approach that we can take to this initial problem, and then we can use clues that we ultimately unravel from this case to decide, like, are we dealing with a primary pulmonary process or a primary cardiac process or a primary vascular process here? I'm curious, Charmaine, what are your thoughts?
No, that was fantastic. I have very, very little to add. And I'm just kind of like filtering the patient's like current hospitalization, your schema through that. So I think the question we're trying to answer is that, is it a complication of this hospitalization course, or is there something absolutely new that has developed? And I think in that sense, what you were alluding to in terms of the complication is that, is this a complication of MSSA bacteremia, either in a sense of like endocarditis, valvular issues, a septic emboli to the lung? Is it because he's been immobilized? Does he have a new pulmonary embolism? He has like a background of AFib. Is this AFib with RVR that has led to like flash pulmonary edema of some sort? Is a new development of heart failure, as you mentioned? Or is it, a pneumonia that he's at risk for just being in the hospital? Those are the things that I'm kind of thinking about. And also like going from like 2 liter to high flow nasal cannula, that is significant. So this is someone that I would be thinking about working up as soon as possible and getting some more information.
Yeah, let me give you more information. Just as a background, the patient has no smoking history, doesn't drink, lives with his wife. He works as an accountant. Prior to this hospitalization, his home meds were insulin, aspirin, atorvastatin, and amlodipine. A review of medications in the hospital, as it was a transfer, so they give you the more medications, included low molecular weight heparin, meropenem, daptomycin, insulin, metoprolol, and amiodarone. And then that's it for background history. The no relevant drug allergies. And then if you want, I can pause there, or I can jump to the vitals and exam.
Do you want to give us the exam as well? And then we'll tackle both these two.
That sounds good. He's afebrile. His heart rate is 105. The blood pressure is 137/77. His oxygen saturation was 95% on 12 liters of nasal cannula. On exam, he was noted to be tachypnic, taking deep breaths with a respiratory rate of 23. He was on neck exam, no elevated JVP was noted. And then on cardiovascular exam, we did not auscultate any murmurs. And then on pulmonary exam, he did have decreased breath sounds at the lung bases, but no wheezes or crackles. And then the exam was otherwise normal. Obviously, other than the surgical wound that was did not seem significantly different as what was described to us.
Awesome. What an interesting case. Thank you so much, Yusuf, for presenting. So I'll tackle the background a little bit more and then leave the exam to Jack to walk us through. So we kind of touched upon his past medical history in the first aliquot. The other thing to just mention, looking at that list, is that, he's been very acutely sick, inflammatory condition, and thinking about a higher risk of like coronary events during this like acute illness period. So that's something to think about as someone who's already has a background of coronary artery disease. So, again, like I think when it comes to acute hypoxemia, like cardiovascular and pulmonary are like the two things we're mostly I'm thinking about. In terms of like his medications, you know, we always like want to think about the side effect of medications. And whenever I see amio, I have to pause. The question is like, how long has he been on amio? Usually long interstitial lung disease or tendonitis picture that can happen with amio. It could present the first year of that. If it was like during this hospitalization, it would be a little acute for that. However, I've like seen one case of amio toxicity that developed quite early on. So that's something to think about. Again, that's usually like you have ground glass opacities, you have nodular findings on imaging. So like, I see a tube of truth in his future. So that's something in the background that I'm thinking about. And then in terms of like his heart-related behavior, really, I think like again, like knowing the smoking history, always helpful. We don't have to worry about it here. So I'll pass the mic to Jack for the exam.
Awesome. I love that point, Charmaine. I think it's such an important cue to be like, that is one of those diseases that we won't think about or that won't come to us unless we explicitly think about it. And so yeah, that is such a phenomenal point. I think in terms of just like, how does the exam help us, right? If we use that framework of sort of asking ourselves, which of these possible organs is on the hook, right? Is it the heart that's driving an alveolar filling process? Is it the pulmonary interstitium versus possibly the vasculature? I think the exam brings another possible underlying etiology into the fold here, which is actually that maybe there's also a pleural-based process as well, right? If we hear decreased lung sounds at the bases, bilaterally, right, that potentially invokes the possibility of bilateral pleural effusions. And I think what I'm contending with here is that both cardiac causes of cardiogenic pulmonary edema and cardiogenic pleural effusions usually come with a syndrome of general volume overload, which we don't seem to have here necessarily, right? What we have is no elevated JVP. It sounds like there's also no prominent systemic lower extremity edema, right? And so the absence of a syndrome of volume overload, I think, decreases the probability of a cardiogenic cause. I'm saying decreases the probability rather than takes the heart off the hook, because there are a couple scenarios where you can have heart failure that is primarily going to manifest as pulmonary disease. And one of those conditions is going to be in the setting of a relatively acute valvulopathy, right? Acute mitral regurgitation can lead somebody to dump fluid into their lungs very quickly before we necessarily see a lot of volume retention overall. The same thing can happen with acutely progressive aortic insufficiency, right? As that whether if we just think about mitral regurgitation acutely, right, blood is going to follow the path of least resistance. And all of a sudden, if we open up that gate that is usually closed that supports blood flowing out of the heart, right, we open up that gate from the mitral valve into the left atrium, blood is going to follow the path of least resistance, and the very high afterload aorta is going to be an unappealing place for the blood to flow, but the low pressure left atrium and the low pressure pulmonary vessels is going to be a very nice place for us to see backflow. And so I think, as Charmaine was saying, imaging is going to be very, very helpful here for helping us get a sense of, do we see characteristic imaging findings that suggest pulmonary edema, or do we see, and potentially thinking about echocardiography here, particularly in the setting of the MSSA bacteremia. But that's one way that we could reconcile the discrepancy between the absence of volume overload, but the possibility of an underlying primary cardiac etiology here. And then from the pulmonary perspective, right, if we think about whether it's an acute alveolar filling process from infection, or possibly interstitium, or possibly the pulmonary vasculature, I think all of those are on the hook here. And I really do think that imaging is going to be key for us here, right? If we see a dense focal consolidation, pneumonia becomes much higher. If we see diffuse ground glass opacities and bilateral pleural effusions, that's going to increase the probability of cardiogenic pulmonary edema, right? If we see sort of scattered multifocal ground glass opacities, then that might invoke something like amiodarone-induced lung toxicity, or some other idiopathic interstitial pneumonia, like organizing pneumonia, or something like potential interstitial lung disease. So I'm right there with you, Charmaine. I feel like the pattern of the imaging is going to be really, really helpful here for us to sort of weigh the probability of these different, weigh the probability of where the primary lesion is for the ultimate underlying cause of this hypoxemia.
Yeah, I love that. And I think the thing that oftentimes in the hospital we're grappling with is like what type of CT imaging you want. He's on low molecular weight heparin, so that decreases the chances of pulmonary embolism. However, in a patient who's been acutely sick, it doesn't take it away. So thinking about like, oh, we can get a CTA angiogram with pulmonary embolism protocol to view the vessels. Oftentimes that can cause the parenchyma evaluation not to be as accurate. So you always like kind of have to grapple with like, what are you most worried about? And again, like, what is the sensitivity of your imaging that you're gonna get? So in this case, I still want to look at the vessels. I think he's been in the hospital as long enough time, died, especially with, there's like, with the poem, there's a decreased breath sounds at the bases, but otherwise, if it's truly clear, then I worry more about something going on to vessels. So I think I do want that contrast. What do you think, Jack?
I've been fooled once before by trying to analyze the possibility of a PE with a non-contrast imaging study with you on Wednesday VMR. Fool me once, but hopefully not fool me twice here. So I will definitely take the contrast here.
Okay, so I'm going to give you just some labs and then I can give you the imaging for sure. The amiodarone was started, this hospitalization actually, for AFib and has not been like a long-term medication. The initial labs were notable for a white blood cell count of 25.9. That white blood cell count was predominantly neutrophilic at 90%. The eosinophils were elevated at 6% with an absolute count of 900. Otherwise, the platelet count was 553, and the hemoglobin was 12, which is at baseline. The electrolytes were notable for a creatinine of 1.4, which is at baseline for this patient, and a troponin was normal. There was no other notable electrolyte abnormalities. The CTPE was done, and Marino has it and is able to share it. This was the lung window. And this is the non-lung window, vascular window.
Can we see the lung window again? Sorry, for me, skip, so I only saw the top part of the lung. Oof. Thank you.
That's all I had for this aliquot. And if you want, I can give you the official read.
I'll take that as well.
It was read as diffuse ground glass opacities and reticulation, bilateral moderate pleural effusions, and the suggested diagnoses were by the radiologist were cardiogenic pulmonary edema versus non-cardiogenic edema / acute lung injury.
All right. Well, I will talk briefly about the labs here and sort of like ask ourselves what we can possibly do with the laboratory findings here. And I think one of the things that I'm having, or that I think is not necessarily a dilemma, but at least warrants the need to explore two potential hypotheses here, is the fact that we have an acute hypoxemic pulmonary syndrome in the setting of a sky-high white count and a neutrophil predominant leukocytosis. And if we just think about this epidemiologically, right, we still have to at least explore, and I think really take seriously, based off of the base rate of disease, a hospital-acquired pneumonia here. This is somebody who was recently bacteremic and is now having sort of a progressive hypoxemic pulmonary syndrome with sort of diffuse opacities here. And so I think one hypothesis to say this white count is being driven by whatever pulmonary process there is. And I think a pulmonary infection in the hospitalized patient is incredibly important here. The flip side to that is that this is somebody who has been on very broad spectrum and very appropriate antibiotic therapy for several days that should treat at least some causes of hospital-acquired pneumonia. One thing to note here is that this is somebody who is taking daptomycin, and daptomycin, if we think that this Staph aureus that was in this person's bloodstream made its way into the lungs, from a management reasoning perspective, it's worth remembering that daptomycin is actually inactivated by pulmonary surfactant, and so it's not going to be good for MRSA pneumonia, but that doesn't necessarily seem like what we're dealing with here because this person's blood cultures grew MSSA. But it's at least just keeping in the back of your head that daptomycin is not going to be effective for MRSA pneumonia. But meropenem and I imagine potentially other antibiotics that he received or were added over time here should treat many of the common microbes invoked in hospital-acquired pneumonia. For example, meropenem is going to do a great job of treating nosocomially acquired GNRs. The alternative hypothesis is to say that the white count of 25,000 is just related to the recent neck fash and the postoperative state where we can see very, very high white counts, and we can actually erase that out of the fold here. If we erase that out of the fold here and say, okay, well, what do we have? We have a progressive hypoxemic syndrome and a little bit of eosinophilia, though total eosinophil count here is like right around 1,500, I think. I used a calculator for that. I won't do math on the fly live in front of people, but an eosinophil count of around 1,500, and then this diffuse, what seems like diffuse GGO seen, at least warrants the possibility of something like an acute eosinophilic pneumonia. But there's all kinds of other possible interstitial pneumonias that we could think about here, and I'll turn that over to you, Charmaine, for any other comments on the labs and also the imaging studies.
Ooh, I love that. Is it EOS? What are you doing? Are you going into the lungs? I think that's a really, really good question and worth entertaining here. I think in terms of the imaging, quite significant. And I always like when I look at the imaging, my first question, like, is this explain the hypoxemia? And like the diffuse ground-glass opacity, the degree of hypoxemia, now we know what to tackle. In terms of the ground-glass opacities, I mean, the question is like, is it water? We haven't had a really good, good story for like a flash pulmonary edema or as like a valvular disease. However, like I think getting it TTE is never a bad idea, especially in someone who has a background of MSSA bacteremia. I think Yusuf, he's probably cleared his cultures by now, correct? He's not actively bacteremic. Okay. The other things to think about when you think ground-glass opacity infection mentioned, he's on good spectrum antibiotic for that. And then the other things to think about is like, is there like a hypersensitivity pneumonitis of some sort that is going on? I would think about holding that amio for now, and I would talk to pulmonology here. Something bronch would be helpful. He has quite of an oxygen requirement, so that might not be possible. The other things that I'm thinking, like getting an ABG to think about his the other thing you worry about in the setting of those ground-glass opacities are like ARDS, and again, like ARDS can have, we still need to figure out why, why he's having it. So thinking about infection, the other one that I think about is like PJP. He doesn't have the usual risk factors. He hasn't been on immunosuppressants either. A good idea to also get an HIV test just to make sure he's not immunocompromised here. And then thinking about more like hypersensitivity things, thinking about the EOs as well. I do think we need more, at least like a BAL or something to get a little bit more information to help us progress. Anything else, Jack, that jumps out to you?
No, I don't think so. I think, I don't think I have anything else to add.
So to give you more information, the TTE was done as requested, and it was within normal limits, so normal EF and no valvular abnormalities were seen. On further blood work, so the blood cultures remained negative. The CRP was elevated at 104. Sputum cultures and pneumonia PCR panels were sent out, and those were all negative. Pulmonology was also consulted, who suspected a diagnosis, and I'm going to stop right there, and I think the next aliquot will reveal the diagnosis.
Austin, what a great point in the chat. Yeah, the other medication that we should think about is daptomycin side effects. And again, whenever there are medications, just look up the side effects if you're not sure, especially like a medication that we don't use as often. And I think dapto with the risk of eosinophilic pneumonia, that is absolutely such a great point, Austin. Thank you for putting that chat. So that's also definitely a possibility. Jack, what are your thoughts?
Oh man, I think this is such a fun place to find ourselves in. Yusuf, I missed the last sentence. My computer glitched out over here that you were saying about after pulmonology got involved, at the risk of analyzing incomplete data. Could you just share that last sentence again?
Pulmonology suggested a probable diagnosis, and the next aliquot will reveal it.
Oh, okay. Well, gosh, I guess if we were to just look at what the problem space is here, I think what we have is a fairly rapidly progressive hypoxemic syndrome that seems to be characterized by diffuse ground glass opacities, a normal TTE, and then negative blood cultures in the setting of somebody who recently had severe acute critical illness. And I think one of those possibilities is just general run-of-the-mill ARDS, which is certainly not impossible here. But there may be some things that don't necessarily perfectly fit with that picture, given that the critical illness seems like it was really, really effectively managed. Other things that can do this, as Charmaine was alluding to, are some of the atypical infections, but it seems like those hypotheses have fallen away. So if we think about, okay, let's say that it's not just run-of-the-mill ARDS, and what we're actually dealing with is that little first part of the last sentence of the CT study, which is acute lung injury, right? Things that can cause acute lung injury include ARDS, but there's also other sort of non-ARDS, non-infection related things that can cause that syndrome. Some of them include some of the idiopathic interstitial pneumonias, but most of those are going to be more subacute to chronic in nature. There are a couple of them that can be relatively acute and crescendoing. One of those is just acute interstitial pneumonia. Another one is sort of a rapidly progressive form of idiopathic pulmonary fibrosis, but that is one that I think would certainly need PULM's help with, because some of the characteristic features of the CT scan, things like reticulation, traction bronchiectasis, and other things aren't necessarily present because of how acute it is. And then the eosinophils in the acute setting here warrant the possibility of something like an acute eosinophilic pneumonia, as we talked about, and as Alec mentioned, and Charmaine elevated just now. And I think one of the things that's important to mention about acute eosinophilic pneumonia is that unlike chronic eosinophilic pneumonia, where we usually have higher levels of peripheral eosinophilia, AEP, or acute eosinophilic pneumonia, can have variable peripheral eosinophilia. It can be low level, like what we have here, or it can be very, very high level, but it really depends. So the presence of a low level eosinophil count in the setting of the recent daptomycin and these imaging findings is not incompatible with acute eosinophilic pneumonia. What we really need for AEP to make a diagnosis is a BAL, where you'll usually see more than 25% of EOs on the BAL there. So that's one of the idiopathic interstitial pneumonias. And then the other one is something called organizing pneumonia. And organizing pneumonia can be secondary to things like infections, things like medications like amiodarone, which Charmaine mentioned, and then a whole host of other things. Oop, lights went off here. Like underlying autoimmune disease or connective tissue diseases. So I think of those big buckets, right, ARDS, or an idiopathic interstitial pneumonia, the IIPs being acute interstitial pneumonia, acute eosinophilic pneumonia, rapidly progressive IPF and acute organizing pneumonia, I don't know that I can really honestly weigh the probabilities a ton. The imaging findings are a little bit beyond my own knowledge base. I think I could share some prototypical ones, but I think my like illness script flexibility for many of the possible imaging findings is so limited here. And so I think the BAL may give us a clear answer, right? If we see a ton of eosinophils on the BAL, that might help move things in favor of acute eosinophilic pneumonia. But beyond that, I think I would be kind of guessing in the dark to say, oh, this imaging is suggestive of this diagnosis over this one, because my CT imaging is just not nearly that nuanced.
Oh, that was so brilliant, my friend. And also shout out to Yaz, who also mentioned Dapto and EOS earlier on, and I didn't see it. So thank you. Oh, you guys are just so brilliant. I totally agree. I think if you had to ask me to put your nickel down, I think it would be on medication side effect, whether that is Dapto or amio. I think EOS makes Dapto being on the hook a little bit more. However, I would love to see a BAL to confirm that. So yeah, we'll see. I'm excited to learn from you, Yusuf.
Thank you for the discussion. I've heard dyspnea discussions hundreds of times, and I still learn something new every time, especially from you both. The pulmonology team did a chart biopsy, and they were doing the chart, and they were noting that prior to daptomycin getting started, the patient was on vancomycin, and they noticed a possible like temporal relationship with starting dapto and the patient having this new oxygen requirement. They also were discussing, like you said, of considering a BAL, especially to clinch the gold standard of diagnosis of daptomycin-induced pneumonia through BAL. However, they said, given that the high likelihood of diagnosis is likely secondary to the dapto, they recommended to switch the dapto off and start a different antibiotic, in addition to starting a corticosteroids. And that's what the team did. The patient was started on steroids, daptomycin was switched with rapid improvement in symptoms. The oxygen requirement essentially went to 0 and it resolved. And the final diagnosis was daptomycin-induced eosinophilic pneumonia.
Medications.
What a great case, Yusuf. Thank you so much. Yusuf, I'm curious, what, if anything, was the conversation like around starting relatively high-dose corticosteroids and this, if not acutely, very, very recently infected patient? That seems like a very interesting management tension to hold.
The patient had been on antibiotics for a little while now, longer than the 24 hours. It's been for about a week. And they had like very broad coverage, like you mentioned. And because of the diffuse opacities and negative cultures and the negative pneumonia pathogen panel and the high suspicion for this side effect due to the medication, the pulmonologist preferred to actually just start the corticosteroids. They're on review of literature. Most cases of dapto-induced eosinophilic pneumonia have been treated with steroids without randomization because the cases are so rare. But daptomycin is one of the most common causes of eosinophilic pneumonia.
I love that. I love that framing of like, we have two things. We have the infection problem, and then we have the eosinophilic pneumonia problem. And the infection problem is much more controlled and much less likely to be negatively affected than the lung problem, which we need to get under control. So that's awesome. So, I mean, what other reflections do you have?
Such an amazing case. Thank you so much, Yusuf, for presenting. I love cases like this, especially like acute hypoxemia in a hospital. You see it all the time. I love the workup. It was just such a cool exercise and adaptive. So thanks for everyone in the chat for all of your wisdom. It's so fun doing these cases with you all.
All right, Bea, do you want to take us home with these fire teaching points here?
For this amazing case. So we started with short concern, and we said that hypoxemia, shortness of breath, so we should go for an algorithm for hypoxemia. We picked an anatomical algorithm, and in particular, we said, I think I've lost the connection. Have I or not? The anatomical
I can hear you.
algorithm, we have mentioned the alveolar. Okay, yeah. I think it's just the Google Doc that is reconnecting, but Zoom is still ongoing. And so the alveolar airway interstitial vascular etiology, and regarding the alveolar etiology, could have been a pneumonia or an heart failure. In issue regarding the vascular etiology, we have mentioned the pulmonary embolism that was very likely hypothesis, since our patient here was in a post-op, which we know is a risk factor, and he had an MSSA bacteremia recently. We have also asked ourselves whether this was a complication issue or a primary one. The amlodipine is a drug that, and once again, asked ourselves whether it was a heart. We didn't see volume overload here, the genic issue, yet we've mentioned that in acute onset of aortic insufficiency and mitral regurgitation, we have cardiogenic etiology and do not have a volume overload. And we've mentioned that the imaging would have been crucial. Like this, in particular, in a pattern, and a CT angiogram repeat. So CT might have been
Jack, I don't think the audio is working for us.
Yeah, Bea, I think we lost your audio connection. I'm so sorry. I will just we will give folks a couple seconds just to read through
exam would have asked for. And in a patient that was with a progressing hypoxemia, and in our patient was mentioned that is the acute eosinophilic pneumonia, and the acute eosinophilic pneumonia, like the chronic, can have count. We would also
All right, folks. I think we will close it out there. Bea, thank you for working through the teaching points there, despite the internet troubles. And thank you all so much for coming out today for another Wednesday VMR. I hope everyone has a great rest of their day, and we will see you next time. Take care, everyone. And Marino, thank you for scribing this morning. Yeah, phenomenal job, Marino. And also not only scribing, but plug in some teaching pearls in the chat. And Yaz, one more congrats for the FIRE early diagnosis there. Thanks everybody for a wonderful day, and we'll see you soon. Take care.